Good evening. I will talk about material for this presentation gathered from the GOC Shoulder Hospital in Bonn, Germany, Al Salam International Hospital in Cairo, and Dar al Fuad Hospital in Giza, Egypt. Between 2013 and 2019, we had 876 cases of recurrent anterior dislocation. All of them had an inferior capsular shift, 220 with an overlap Bankert repair, and 44 with shift-sick Bankert repair, and there were 54 cases of revision. The treatment and results were very good, excellent in most of the cases. The strategy of the surgical treatment is to define the lesion, establish a healing potential, a healing site, and anatomic repair of soft tissue lesion to the labrum, rotator interval, capsule, or rotator cuff, and reconstruction of bony lesions. Also avoid injury to normal tissue. The frequency of the lesions are 90% elongation or redundancy of the capsule, avulsion of the labrum in average 30% of the cases, a Bankert lesion, and very rarely a tear of the capsule or Hagel lesion. Up to the early 80s, there were more than 100 surgical techniques of recurrent anterior shoulder dislocation. In the late 70s, it was crystallized on Bankert repair, but the results were not very satisfactory. Charles Neer, in the beginning of the 80s, he introduced the reconstruction of the anatomy as a golden standard for repair. It was based on repairing a labrum avulsion or a Bankert lesion with a Bankert repair, enlarged capsule volume with the inferior capsular shift, and treating the glenoid defects with either a bone block or a Bristow or Latarjet, and the large Hill-Sachs lesion with the bone block. The inferior capsular shift was described by my fellows before. Also, Carter Rowe has modified the Bankert repair by making a vertical incision in the capsule and thus making a vertical shift to the anterior capsule. As I said, also the Bristow and Latarjet and bone block for the defects. In the era of arthroscopic treatment of the recurrent anterior dislocation, which was done in the beginning with Elleman, noticed that the problem in the treatment was not addressing the anterior capsule. And this was also proven in many studies done according to that. So this problem first was treated then with an arthroscopic plication, which is making a medial capsular shift to the Bankert repair in order to shorten the anterior capsule. Also, closing the rotator interval, if it is wide, has added to the anterior stability. The arthroscopic inferior capsular shift, as said before, was used in the late 90s. It is an arthroscopic treatment of the simulating the inferior capsular shift described by Neer. It's done by making a horizontal incision between the inferior and the middle glenohumeral ligament, then a vertical incision, and then pushing a suture through the flap and pulling the flap upwards and shortening and doubling the anterior capsule. Very important is an anatomical postoperative immobilization. Put the shoulder in its neutral anatomical position in order to have the healing of the capsule giving the same size vertically and horizontally of the anterior capsule. The pathologies found are mostly hyperlaxia and redundancy in 95% of the cases, associated with Bankert repair in 32%. Bankert lesion alone was in 5% of the cases. Rarely were bone defects. And other lesions were also present, but they didn't change on the major strategy of the treatment. The overlap Bankert repair is used to fix the labrum to the anterior glenoid rim with sutures by making a hole in the anterior glenoid rim, passing a suture with a so-called PS wire, the wire with the suture in the anterior, and then tying the labrum to the anterior glenoid rim. Here we see, after abrasion of the anterior glenoid, the wire pushed from the back and make a hole, and then the suture is passed through, pulled through the labrum, and then tied to the glenoid. This is on the left before surgery, the MRI, and on the right after surgery, showing the complete healing of the labrum. In 1999 have published that putting the shoulder in external rotation in case of first dislocation have better results than internal rotation. That was because when putting on the capsule, you pull the labrum back to the anterior glenoid, and in the first time dislocation, the anterior glenoid is still bleeding, so immobilizing it in external rotation lead to healing of the labrum to the glenoid. This inspired us to use this technique by creating a bleeding surface on the anterior glenoid and then doing an inferior capsular shift. These are in cases of recurrent dislocation, and thus pulling the laterally and having the same effect as the external rotation and immobilizing the shoulder. This is a case pre-operative and post-operative 6 months later. In case of bony Bankert, with the same transosseous repair as we do for the labrum, the over labrum repair, by putting the suture through the anterior glenoid and then through the labrum, and then tying the broken fragment back to the glenoid. Here we see the fracture, and after passing the suture through the glenoid and the lamina, then tying it back. In case of a defect in the anterior glenoid, larger F, you use a bone block or lateral J. In lesion, more than 10%, we did the remplaçage, but recently we have the patients have problems with that, and we try as much as possible not to use it by making a solid anterior capsular reconstruction. Also, if the del sac lesion is large, we put a bone block arthroscopically. The bone block will be cut according to the size of the heel sac, and it will be pulled with sutures inside. As we see here on the monitor, the bone block is in the heel sac defect. It will be tied then with sutures. In case of an Hagel lesion, also we fix the Hagel lesion with the wire and the suture by making a mattress suture through the anterior labrum and tying it from behind. In old patients, fracture of the greater serous porosity or posterior rotator cuff tear is not uncommon. So we have to look for that and take care to treat that. In case of open rotator interval, we suture the interval using the giant needle, or by making, if we make an inferior capsular shift, which is most of the cases, we also interval with it. This is a case of a failed repair, complicated by osteoarthritis, as was mentioned also before from my colleagues. And here we remove the anchors and make a salvage surgery. This is also a Bankart repair, and there's a disturbance of the blood supply to the cartilage leading to osteoarthritis. There's another case with complete osteoarthritis, which ended by total shoulder replacement. Here's an anchor case with damage to the glenoid and fracture of the glenoid. And this is also a case with recurrence due to capsular redundancy and supraspinatus lesion, which was not treated. And this caused a damage also to the head. It was repaired by repairing the supraspinatus, suturing bad transosseury, and then making an inferior capsular shift. It is also a recurrent case. We see the sutures from the anchors are then removed, making bleeding surface anterior acromion, suture through the anterior glenohumeral ligament, and tie the labrum back to the glenoid. And after that, we do then, here's a tying, then we do the inferior capsular shift. This is another case of a loose anchor which has damaged the shoulder, and here's the head with the damage. We did then an inferior capsular shift and abrasion to the head. And this is the anchors which we removed, and the patient 1 year after surgery completely satisfies the normal range of motion. This is an 18-year-old patient who had an operation for a Bankart lesion or recurrent anterior dislocation, and the anchors caused also damage to the joint with infection, and the joint was unfortunately completely damaged, so that a salvage operation with the removal of the anchors and arthroscopic debridement didn't help, and he got a total shoulder replacement. He is now certified, good range of motion, no pain, but we hope this will stay for a long time. We gathered from the literature 998 cases of Bankart repair with application. And we found that the redislocation, these cases were average 9.3%. Compared to the cases which we did, it was 0.35%. Also, the function and athletic activity was regained in the group for 55% completely, while in this group of the anatomical reconstruction in 95% of the cases. In summary, it is only one thing I want to say, that it's arthroscopic reconstruction of the anatomy, as Neil said, in the 80s, and this is actually our experience that brings the best results. Thank you very much.